going to hand over to Tara.
Hi everybody, so my name is Tara Hewitt. I'm the Equality, Diversity and Inclusion Lead for University Hospital South Manchester. One of the reasons Angie and Joe asked me to come along is because we work together as part of the Manchester LGBT Cancer Support Alliance, and we hosted the largest ever conference in the UK on trans cancer inequalities, which was opened by our medical director John Crampton earlier this year, which spent a full day with health professionals, trans charities, trans people, looking at the specific inequalities that trans people experience. My background also is that I'm a freelance diversity consultant and have worked across various NHS trusts in the UK, supporting them looking at health inequalities. I lecture health and social work students at different universities, and I've worked across the prison and forensic hospital estates, looking at equality and inclusion, both with staff and directly with patients and prisoners, so there's a broad range of experience there. We've also, as a hospital, co-founded the Trans Equality Legal Initiative, which is in partnership with Linklater Solicitors, Garden Court Chambers, Action for Trans Health and Wipe Out Transphobia, specifically looking at supporting trans people's rights in the UK to understand that they have the right to services to be designed to meet their needs. And we've talked very much about that for other communities and making sure that trans people are aware that just because there is a lower level of knowledge, that doesn't mean that they don't have the right to healthcare that meets their needs, and actually make sure that they're supported and receive the care that everybody else should receive. Can we move it forward? Thank you. So I'm just going to cover looking a little bit about diverse identities, because I think when we talk about trans people, we don't always know what we're talking about. Some people have different perceptions about what we mean when we say trans people, and trans is an umbrella term, so we're going to explore some of those different identities. We're going to look at intersectionality, and I think it's really good that we're looking at other identities as part of this work, but we're also looking at the impact being in different social circumstances, being in prison, because actually all of those things interact. They're not in isolation. You're not just trans, you're not just gay, you don't just have a learning disability, you're not just a prisoner. Actually, all of those things, when come together, can make people have different experiences, different levels of privilege, and actually receive different levels of care, even within those same communities. So it's important that we look at those together. I'm going to briefly look at some of the social inequalities that we've already touched on and how that's specific to trans people. Looking at why trans people might have barriers into healthcare because of stigma and historic experiences. That healthcare is about all healthcare and not just about people being trans. And then finally looking at what some of the very specific healthcare issues that trans people might face. So, trans as an umbrella term. Firstly, if we look at the trans community as a whole, how many trans people in their lifetime do you think will be affected by cancer? So in their whole lifetime, how many trans people in the UK do you think will be affected by cancer? Who wants to have a guess? There's a number. Do you have a number? Have a big figure? 50,000, did you say? Not percents. So this is numbers of people in the UK. How many numbers of people in the trans people will be affected by cancer in their lifetime? It's also making you think of how many trans people there are, so. 50,000. Does anyone think it's higher than 50,000? Put your hand up if you think it's higher. Higher? Okay. Do we think it's 100,000 or higher or lower? Higher than 100,000? Put your hands up if it's higher than 100 or lower than 100,000. Put your hand up. So I think roughly people think it's a bit lower. 300,000 trans people in their lifetime will be affected by cancer. So when we're talking about trans issues, sometimes people think we're talking about a very small number of people, and actually that's a big number of people actually needing access to health services that at the moment aren't always designed to meet their needs. There's 600,000 trans people in the UK. Most of the information and support says that trans people are more likely to have cancer, they're more likely to die of cancer, they're more likely to be diagnosed late at cancer, and that's what we're going to look at some of those barriers as we go through the presentation. So trans is an umbrella term. Trans is a term to talk about a range of different people, and historically we've used terms such as transsexual, which isn't used very much now, but it tends to talk about people that have permanently transitioned from one gender binary to another gender binary. So you talk about people who transitioned from being male to female, but it's nothing to do with surgery, it isn't to do with medical care. Often when I talk to people about being trans, people almost legitimise it by saying, well, it's about surgery and about what medical care they've accessed. But simply saying that they are them, and this is how they're going to live their life permanently. So that's where that sexual generally comes from. Drag king and drag queen are people that dress up in a very over stereotypical way of a particular gender for entertainment purposes. We've all heard of drag queens, but drag kings tend to be an area that we often don't talk about, which is just the opposite way around, and it's becoming more mainstream. Cross-dressing, there's two types of cross-dressing. So you've got people that fetishistically cross-dress, so they wear clothing to get a sexual desire out of that clothing of the opposite gender. It generally tends to be associated with men wearing women's underwear and women's clothing. I don't know any women that wear boxer shorts and find that sexually arousing. But if you do, that's cool, because actually we're all very diverse and we have diverse sexual appetites as well. And actually, one of the things that I find quite challenging is when people stigmatise different identities and make judgments about them because of where they are. And actually, as long as somebody is happy and living their life the way they want to and expressing themselves, why should any of us make a judgment about that? Transvestite, again, is quite an older term, but is still used by some people to talk about themselves. It generally means somebody it's more than clothing, it's going out and expressing themselves in a way. It's the social element, being interacted with in a particular different gender type to themselves. So normally somebody might be identified as male, but at a weekend or part-time might like to go out and be viewed as Sarah or viewed in a female identity. They don't view themselves as that, it's just an expression of part of who they are rather than their whole identity. And often people use different language to talk about now, but it's a historic word that you might still hear and use. Non-binary and genderqueer. So the non-binary community is much bigger than many people actually realise. So the amount of people that don't want to use pronouns such as she or he, much rather use the terms like they, ze, their, depends, there's different pronouns that people like to use. It's important to ask somebody how they want to be interacted with, and don't just make assumptions that you know the words that somebody wants to talk about themselves. I generally talk about everybody in the term they, or use their name until someone's told me and I know a little bit more about somebody, rather than making assumptions. And I think a big area is when you're on the telephone, and if you run a service that uses telephone, when people automatically say sir or madam without actually getting to know the person that they're speaking to, and that can have a big impact on all trans people. But if you don't use any of those terms and actually use a different pronoun, then actually it's going to have a particular impact on you. So we need to make sure that we're getting those issues right. Genderqueer and queer identities. Many people actually use the term genderqueer, and it tends to mean, why should we label people? If gender is really personal to us, why should you make a judgment about what my gender is based on what I'm wearing, how I talk about myself, what length my hair is? You could spend a whole session exploring what genderqueer and queer identities are, but it's been aware that they exist. A lot of groups are now LGBTQ that you might see, and actually we need to be using that language if we're going to make people feel comfortable in our services. So we could spend all in those identities. If you want to come have a chat at lunchtime, I'm more than happy to come and talk about them more. So I already mentioned intersectionality. I think it's important that we understand that actually many of us have different levels of privilege, actually engage with the world differently. So although I'm trans, I'm also middle class, I'm not black, I'm white, and actually my networks may be different from somebody that is maybe homeless, is maybe suffering racism, and maybe has a learning disability and experience additional barriers to those that I might face. But there'll be barriers that I face simply by being trans, even though I have those other privileges. So actually that interrelationship is really important. Don't just stereotype and pigeonhole somebody in one of the protected characteristics. So we said already about social inequalities, but specifically for trans people, 20% of trans people are unemployed or not in work, and we know that that leads to a greater risk of cancer if we look generically in the population. Trans people are more likely to be homeless, so 25% of youth homeless in the UK are LGBT, so a big chunk of those are trans. Trans people can often experience isolation and will receive less family support. So we know that social isolation, so we're talking about drinking and smoking, one of the reasons, other than the fact that people enjoy doing those things, like everybody, whether you're LGBT or not, is if you're socially isolated and don't have a lot of support, often you turn to smoking and drinking just to get you through the day. And that's increasing people's risks because society is leaving these people behind and actually leading them into that isolation. Trans people have higher rates of smoking, and a significant number of trans people are sex workers and experience sexual exploitation in the UK, again, which can mean that they're not as open with health professionals because they're worried about stigma that sex workers experience. And actually there's a big number of trans people that work in the sex industry but won't be open or feel that they can't fully engage with health professionals because of the judgments that people are still making. And trans people have higher rates of secondary mental health issues, and again, we know people with mental health issues are more likely to be diagnosed later with cancer diagnoses and receive poorer qualities of treatment. So 80% of trans people self-harm, 40% attempt suicide. They suffer all sorts of different barriers in engaging with those services. So, stigma and historic experience. So one of the things when I talk to people, they say, well, why wouldn't trans people access a fantastic health service that's been rated as good or as outstanding, or as a hospital like our hospital in South Manchester, where we're looking to do some of this, to do a lot of this work, is because of past experiences. I can speak for myself that although I work in the NHS and I've speak in the media and I've done loads around this agenda, and I'm quite confident in advocating for myself, it takes a lot of energy for me to step up to go to a GP because of the amount of negative experiences I've constantly had within GP services. I've been sat next to a GP where they've rang through to reception and said, I've got a man sat here, can you get me his records? Just really, really inappropriate language. I had a nurse who was taking my blood pressure, who I transitioned about 10 years ago, but so 10 years later, I've still got somebody saying to me, so how far through the transition are you? I'd just gone for my blood pressure check. What on earth had that got to do with the appointment that I was in there for? If you look at the hashtag #transdocfail on Twitter, you can see thousands and thousands of examples of trans people talking about their experiences. And that's what's on people's minds. So unless you do something to overcome that past experience and show that services have changed, and you visibly shout about it and show that you've thought about trans people, you're not going to actually get people to come through the door in the first place, or they're only going to go to the GP at the very last minute. And if they're not going to the GP when they've got symptoms, they're going to be diagnosed later, and that's going to lead to people dying more of cancer, which we're seeing at the moment. Poor language we've mentioned already, so people using inappropriate pronouns. I've been in clinical consultations where they'll revert to using different pronouns in private than they do with the person in person. So you've got a trans woman and they'll be talking about her as her and she in person, but when they go into their MDT meeting, they'll be talking about that person as he. Now, why would we be changing our pronouns in that space? It would be like saying we should insult somebody when they're not there because it doesn't matter because they won't hear it, because that's exactly what you're doing if you're not using the language appropriate to those patients. Lack engagement with the community. So one of the things that we've been trying to work with Macmillan around is engaging with specific trans people who have cancer. But if you haven't built up a relationship with the entire trans community first, it's going to be very difficult to find those trans people because the community itself is disengaged from health services. So you've got to actually build a foundation of engagement with the whole LGBT community before you start looking for very specific people within that. Lack of inclusion in information that reflects the lives of LGBT and T people, and not just as an added extra. So that's both about, if you separate your guides into male and female, you're never going to make it trans inclusive. Actually, you can have sections that talk about different identities, but make sure that you don't come up with two separate guides. Because if you are, you're going to find it very difficult to make trans people feel that they're included within that information. But also recognising that LGBT people have diverse lives like everybody else, and that just adding that we recognise LGBT people and not changing any of the content isn't making it inclusive to LGBT people. We need to start talking about real people's lives, their real experiences, and how things can practically help and support them. And I said inappropriate curiosity and expectations for trans people to educate. I remember doing some training with a group of surgeons and surgical nurses, and them telling me that they expected trans people as part of their care off a gender identity clinic to be supported to educate all health professionals in the UK in any appointment that they go into. They should be prepared to be able to educate anybody. Now, I don't know any other group that is expected to deliver the education to the health professional whilst they're going in for an appointment for what might be a very sensitive issue, something that's a big traumatic experience, and then they go in. But you should also make that health professional feel comfortable whilst you're in that space. And that's the language that we're still using when we're talking about trans people. Healthcare, not just gender care. So again, when we're looking at this area of work, a lot of clinicians think all of the health issues for trans people are about accessing a gender identity clinic. Now, out of that 600,000 trans people in the UK, the majority will never step foot in a gender identity clinic or a specialist gender service. And even those of us who have accessed gender-specific medicine, it was for a year, 2 years of our life. Most of the healthcare that we engage with is the same healthcare that everybody else engages with. And actually nobody's spending the time and effort to make that healthcare inclusive. If you go to a trans health conference, it's all about gender identity clinics and specialist gender services. They're not talking about people dying of cancer, respiratory health issues, and other health issues and mental health services, and how we can make sure trans people are including in those. And that's what I want to hear people talking about, all healthcare, not just gender identity specialist healthcare. So trans-specific health needs. So this is about some of the real technical information that trans people can have very specific needs that clinical staff and doctors need to be able to understand. So depending on someone's surgical outcome from surgery, if they've had surgery as a trans person, trans women, their urethra can sometimes be pointing in a different direction after surgery, which can lead to a rupture of the urethra when you're inserting a catheter, if you're actually using a catheter. Now, lots of clinicians won't know that, and actually it can lead to somebody's urethra rupturing. Now, it's a really technical piece of information that you will not learn unless you go to some training and you have some training on that. So that's a risk of potential harm that people experience. Hormones, so we've mentioned already that there's very limited research on actually the interrelationship between estrogen and hormones that trans people may take, and breast cancers and other types of cancer. And the World Health Organization has said that this is an area that needs investment and needs people to be looking at that research the same way, because we know that hormone can have that impact on different cancers, particularly within women. Body type. So trans people can talk about their bodies in very different ways and can have very diverse bodies. So often when we talk about people who are assigned male at birth, who might have transitioned and identify as women, people have an assumption about what their body type looks like. So when we're looking at guides that are inclusive, they'll go, well, trans women will have a vagina. Well, actually, not all women have a vagina. And I know that can be a very bold statement to make, but we need to start making it and actually being clear that not all men will have a penis and not all women will have a vagina, that people have different body types and we need to engage with the person about their body type. And actually, if you're doing an intimate examination, you need to understand that some people might be more uncomfortable with intimate examinations, not just trans people, actually anybody, for all sorts of different reasons. So if we can make it part of actually just the processes that the dignity that we're delivering in healthcare, that we understand that people might be uncomfortable in certain circumstances, and that we're making sure that we're engaging with them and delivering that person-centered care, then actually we solve some of those issues. Language that we use about their body, so some trans people use the word cock to talk about their clitoris, and some people use the word clitoris to talk about their penis. And so again, if you're working in sexual health or cancers which are involving some parts of the body, actually asking the person you're working with what language they use to talk about their body, so you can reflect that language and make them feel comfortable. You don't have to understand why people do that. You can if you want to. We can come and have loads of time and conversations having that, but just understand that makes somebody feel comfortable, and that's what we're there to do. And if we know it makes people feel comfortable, then we should do it, and it's a really simple thing to do. Additional wellbeing support. So if you've gone through your whole life actually fighting to live as who you are, and then actually had surgery, you've had breasts grow as a trans woman, and then you've had to have a mastectomy, again, that's going to have an additional impact on you than it will on anybody. Again, it's a traumatic experience for anybody in that situation, but understanding the additional mental health or the different mental health impact that might have somebody who's already had gender dysphoria and different experiences about their relationship with their gender, and wider health needs. If trans people are never going to their GP and are actually rarely coming into contact with health services, then actually if you're having a health contact, make the most of it. Talk about a whole range of other health issues with that person, not just about their cancer, because actually they might not have engaged with other health services, and that might be a really great opportunity to do that. And just any questions, we're happy to take them before we go.
Any questions from anybody? Okay, always approaches. Okay, thanks for everybody's time.